We can start now, ladies and gentlemen. Thank you very much for joining today's session on vaccine equity here at the World Health Summit, virtually and in person. We have 90 minutes together today to discuss how equitable or inequitable access to COVID-19 vaccines is today, and also what needs to be done next. I would like to open this session with a brief quote. It's a quote from a speech just recently made at the United Nations General Assembly by Prime Minister of Barbados, Mia Motley. At the United Nations General Assembly, she said, "How many more variants of COVID-19 must arrive before a worldwide action plan for vaccinations will be implemented? How many more deaths must it take for 1.7 billion excess vaccines to finally be shared with those who simply have no access today?" Ladies and gentlemen, vaccination coverage for COVID-19 in 2021 is unequal. While currently about 60% of people in high-income countries have at least had one vaccine dose administered, only 4% of low-income countries can say the same. The pandemic is not over. We've just heard that in a previous panel. Not here, not anywhere in the world, even if it might slowly feel like it in rich countries. We have come a long way. We've developed new vaccines in record time, some of which are using new innovative approaches for triggering immune responses. We've tripled routine vaccine manufacturing capacity, and we've established an entirely new coalition of global partners called Access to COVID-19 Tools Accelerator, the ACT Accelerator, where important organizations in global health work together to get vaccines, tests, and treatments out to those who need it the most. There's been tremendous progress, but then it went a little bit downhill as soon as rich countries bought up all the available vaccine supplies. These countries have now made substantial pledges to share these doses, but many still need to be delivered. So I guess we can conclude much has gone right, but also much has gone wrong. Continued vaccine equity will undoubtedly lead, continued vaccine inequity, of course, will undoubtedly lead to more preventable deaths in this pandemic and to more economic losses. And it will increase the likelihood of new variants emerging, variants which may evade the vaccine protection that we currently enjoy and have in some parts of this world. The WHO has set targets where we need to be quite soon. 40% coverage in every country by the end of 2021 and 70% coverage by mid-2022. As we all know, that's a long way to get to. Currently, the data shows that even reaching the 10% target for every country by the end of September has been failed. And 70% of African nations have not reached that very target. So there's a question of, can we get there? How can we get there? And what can we do that by December, the vaccination rates across countries and across the world are looking better and closer to these targets? This is what we're going to be discussing today. I would like to now briefly introduce the speakers and also my co-chair, whom I will hand over to in a moment for a few additional words and to then question our very interesting panel today. In person here on stage, we have Professor Dr. Lars-Henrik Röller. He's the Chief Economic Advisor to the German Chancellor since 2011. In this capacity, he is responsible for the economic, financial, and energy policy at the German Chancellery. He's also Germany's G7 and G20 Sherpa. So he has organized and prepared a total of 17 summits until today. That includes the German G7 presidency in 2015 and the presidency over the G20 in 2017. Welcome, Professor Röller. We also have on stage Thomas Kühni. He is the Director General of the IFPMA, the Global Association for Pharmaceutical Research Companies, based in Geneva, and he's the Secretary of the Global Biopharmaceutical CEO Roundtable. Thomas Kühni represents the biopharmaceutical industry on the ACT Accelerator, and hence has therefore also a unique perspective of both industry and the global coalition to tackle this pandemic. And we have wonderful speakers online with us today as well. We're very happy to have Dr. Leah Tedesse. Dr. Leah Tedesse is the Minister of Health in Ethiopia. She's been State Minister of Health since 2018. She's an Option specialist and healthcare leader with extensive experience in healthcare and hospital administration, and has worked in government, NGO, academia, and in leading grant-funded programs. Welcome, Dr. Tedesse. We also have Jane Horton. She's the chair of the board of the Coalition for Epidemic Preparedness Innovations, CEPI. And she's co-chairing the COVAX coordination mechanism, the very mechanism that is working to get vaccines all across the world to everyone who needs them. Ms. Horton is a member of the Australian Strategic Policy Institute and the US Institute of Health Metrics and Evaluation. Welcome, Ms. Horton. Great to have you. And last, but certainly not least, we have Dr. Seth Berkley. He is a medical doctor and infectious disease epidemiologist, and since 2011 has been the CEO of Gavi, the Vaccine Alliance. Gavi, as everyone I'm sure in this room knows, is an alliance to improve access to immunization in poor countries. Dr. Berkley has co-created COVAX, the mechanism I've just mentioned, which is the only global initiative that works with governments and with the manufacturers for vaccines to ensure that COVID-19 vaccines are equitably distributed. So that's our very, very eminent and interesting panel. And now I'd like to hand over to my co-chair, Alhaj Assi. He's the chair of the board of the Kofi Annan Foundation and co-chair of the Global Preparedness Monitoring Board, which we've heard a lot about this morning already. He's also was also Secretary General for the International Federation of the Red Cross and Red Crescent, and hence has a unique perspective also of civil society on the ground in many of the countries that we've talked about. Assi, it's great to have you here. Thank you, and I'm handing over to you now.
Thank you very much, Carolina, and colleagues and friends. Again, very welcome to this session. I'm sure when we talk about pandemics, shocks and hazards, we will ask many questions. Have we passed the test of preparedness? Have we passed the test of delivering, for people? Have we passed the test of equity? Have we passed the test of solidarity? All these are questions, that we'll be asking our panelists that will be addressing those questions from their different perspectives. Now, what we often refer to is the fact that science has delivered, and in some instances, even over-delivered. In relatively no time, we have the products that we have today, including the vaccines that we are discussing. Have we passed the test of leadership? Has leadership delivered? Did we have the accountability that we are accounting for, that we're counting on to make sure that people in need, including those that are hardest to reach, that are most vulnerable, will have access, to whatever products, are there, including vaccines? In our jargons, of the SDGs and in development, we call it the last mile to walk. But indeed, if this is the last mile of problems, that should be our first mile of response. But is it the case? What are the bottlenecks, on the way? But also, what are the opportunities that avail themselves? We would like, go through our panel of today, ask, some questions that will help us shed some light, on those issues. And if I may then ask and start with our friend and colleague, Seth Berkley from Gavi. Seth, regarding distribution of vaccine doses, could you kindly draw the picture for us? Where are we on doses pledged by countries and what has been distributed so far? What is COVAX set to deliver and what are the challenges that might impact equitable access to vaccines? Because these questions will be relating to promises made and have we kept those promises or do we risk to break them? And that will be having a negative impact on trust. Over to you, Seth.
Thank you, C, and thank you for inviting us to this panel and this very important conference. And sorry to not be there in person with you, hopefully next year. So let me start talking about COVAX, and then I'll talk more broadly. So today, COVAX will exceed 400 million doses delivered to people in 145 countries. And if we look then at how many doses have actually been allocated, it's now 726 million doses. This is now scaling up, and we expect to see this acceleration and ramp up to dramatically increase towards the end of the year, where we hope a further approximately 1 billion doses will be available for supply to countries by the end of the year. Meaning that we end up with about 1.4 billion doses, of which 1.2 billion are expected for lower and lower middle income countries. In the first quarter of next year, we expect that to increase to being around 2.6 billion doses by the end of March. Now, I think we have to look at, what's happened here, and Caroline has already mentioned this, but we're in an extraordinary time. When we set up COVAX, which I'll talk about in a second, had no idea whether any of these vaccines were going to work. Was it even possible to have a vaccine? And it's extraordinary. It took 327 days for the first vaccine to be used in a patient off clinical trial. There are now 25 vaccines in use. And I think what's important is that as we look at access to these vaccines, the first COVAX vaccine was delivered 39 days after the original injection in a high-income country. That was what we were trying to do, which would have been extraordinary had we continued to move. But I do say and acknowledge that, in fact, that hasn't been the case. And part of it is due to a series of problems that have come in front of us that we do have to discuss, which includes export bans, which includes manufacturers not keeping to the agreements they've made, and of course include high-income countries having bought up most of the doses. COVAX now has a portfolio of 11 approved vaccines. That's the largest portfolio in the world. And the reason we did that was to build a broad and diverse portfolio so that we would be prepared if some vaccines didn't work or had specific challenges associated with them. And so what we proved is that you can put together the advanced market commitments to make this happen. You can deliver at scale. But we initially were stopped dead in our tracks when our largest supplier was told that they couldn't export no further doses, despite having $1 billion of COVAX money and despite having tech transferred the doses there. And it is only when we appealed to the world to donate doses, which they did generously. We have 1.3 billion doses that have been promised. But in terms of seeing those deliveries, we've only had about 150 million delivered so far. And so one of our asks is to make sure that that can be brought up front so we can get those doses to countries now as industry is scaling up. And then lastly, on the industry side, again, industry has embraced COVAX. We have deals with all of the different manufacturers, but the one thing that's not clear is when there are delays. Is this a delay across all of their suppliees, or is this only the low-income countries that are getting delays? And so we've called for better transparency on this so we can understand what's happening. Certainly our perception is that often the delay occurs in the multilateral mechanism, whereas they provide vaccines through their bilateral mechanisms. And of course, that is a challenge. So just to finish, it is critical that we supply vaccines everywhere and that we have equity in vaccination. We are certainly not there yet. It will get better, but what we need is to learn from the challenges that were in front of us and see if we can make it better now and, of course, for next time as well. Back over to you, Asi.
Thank you very much, Seth. Now we can all salute the initiatives taken, progress made, particularly the intentions. But as you rightly said, is it enough? Probably not. Is it fast enough? Probably not. And maybe I will come back to you with the specific asks to manufacturers and others to speed up the process. But I would like now to ask Her Excellency Leah Tadesse, listening, to those numbers and, the deliveries to countries in need. From your perspective, why do you think it is so important to have predictable, reliable vaccine supply, and how does this help plan for successful delivery? Could you give us the perspective of Ethiopia, and by so doing also give us a picture of the number of doses received versus what is needed? Your Excellency.
Thank you very much, Honorable Chair and distinguished delegates. It's a pleasure to be part of this important panel. Yes, indeed, when we talk of vaccine inequity and the challenge with vaccine equity, it's not without recognizing the tremendous progress made, even starting from the developing these vaccines in record time that has been achieved globally, and all the support that different, especially high-income countries have given to the development, as well as commitment to ensure equitable access. And the global initiative through COVAX, with this aim, had launched, and with big ambitions, has been doing huge work in terms of globally achieving this. But also, of course, as mentioned by Seth, and as we all notice, with its own a lot of limitations and challenges. And I think as a country, for Ethiopia, of course, what we were hoping is to achieve within this year, to achieve covering or vaccinating at least 20% of our population. That was the initial totem plan. But of course, when you come to the implementation, the challenge was the delivery of the vaccines due to different limitations and reasons that already Seth had alluded in. So the challenge that it brings to countries is, of course, when you start getting very few doses, then the demand is high, but to keep the momentum, for example, one of the key challenges we had faced was we initially launched with 2 million doses of AstraZeneca, which we rolled out as first dose, but then we couldn't get the second dose on the time that was needed to arrive. So this also creates frustrations within community itself who are waiting for the second dose. And when the time passes, then the hesitancy also is compounded in those communities. In addition, the other challenge was, of course, the unpredictability of when it arrives, so that the stock management, the supply chain also is challenging, because as, for example, as a country large as Ethiopia, we have to deliver in so many regions and in a very distant area. So if we get small doses, but in very short intervals, delivering that vaccine every now and then with that large surface area of a country is very challenging. And that's also compounded, of course, by the short shelf life these vaccines have. Especially, that was the main challenge we have been discussing with Gavi and the COVAX team in terms of the ones that were coming through the dose sharing mechanism. So there's a lot of efforts trying to solve this challenge, and there are progressively, the supply issues have been improving, and I really want to appreciate the efforts that the COVAX has been doing in progressively improving that, and also the commitment of countries has been increasing. But if this commitment was there from the beginning, I think we would have been in a better place, because this happened much later stage after a lot of challenges were already faced. So it is when we work together with solidarity that we can really be all safe. We all know that, but practically when it comes to the practical things, that was really the key challenge. But when we are now thinking of countries, really, I mean, the disparity obviously was mentioned where we are now with 60% versus 4%. So it really requires us to think how do we really fill this gap, and it of course is a continued commitment of countries in terms of allocations and those sharing, but also the pharmaceutical industry. So the waiving of patents, and also really critically thinking about enhancing local manufacturing is I think the time now is to also think about those issues, not only on how do we deliver those vaccines, but how do we improve the access in manufacturing of countries or continents like Africa, in supporting initiatives or partnerships like the partnerships for African vaccine manufacturing. So I think we need to critically think on these bold issues when we are thinking of also long-term solutions while we address short-term issues we have at hand. Thank you so much.
Thank you, Minister Tadesse. We'll hear a lot about what more or better COVAX could do, what more or better high-income countries, could do in sharing doses. We will hear also what manufacturers could do. And beyond those questions, there's some criticism of all of them not doing enough. But can I ask you also, what could low-income countries on their own do and do better, and not always, rely, on either COVAX manufacturers and others, to provide services to their own citizens? What would be your view on that?
Thank you for this important question. Of course, one is definitely, we all know that not all the doses that are coming to countries, low-income countries, are being delivered timely to the communities. And this is a key area on improving the health systems within countries, to have a strong supply chain mechanism, and also strong systems that can deliver very quickly to the communities, as well as, of course, working on all the advocacy and alleviating all the different hesitancy issues. So, and this is the responsibility of countries and governments, the leadership especially, on achieving those, because we are seeing a lot of vaccine hesitancy in all of our countries, and this requires leadership commitment, and at the same time having strong supply chain systems, cold chain systems that can really achieve this in a short time. But also, that's the reason I raised the local manufacturing, is also this is a time where we need to really look and think hard on what should we do as countries. It could be individual countries, but also as regions and continents, to create strong capacity in terms of having reliable systems that can supply for our demands as well. So I hope there will be strong global solidarity to achieve that, but countries need to look inward and look on how do we improve our capacity to achieve this, because there is a lot of potential that's yet untapped that can be explored, and with political commitment, I think a lot can be achieved, and this is a challenging time which is also bringing us such opportunities.
Thank you very much. Let me now turn to you, Thomas Queni. From the perspective of manufacturers, what do you think are the missing elements to ensure vaccine distribution globally? And if you could, give it, that perspective, so that we understand the changes that needs to be made, so that we do not face the same situation in 2022 as the one we have faced in 2021. Over to you.
Thank you very much, Charles. And let me first say, I think we all feel a deep sense of responsibility and urgency, because when we look at how many people are still dying from COVID-19, how many people are still suffering from the pandemic, I think all of us need to realize that we need to do more to fulfill the promise that no one should be left behind, and that we hopefully can end this pandemic in 2022. Now, having said that, I also believe that we should bear in mind how far we have come. I heard Minister Spahn last night saying, who would have expected to have vaccines, large volumes available in June 21. That was the expectation, the hope, if all goes well. And for example, Kate O'Brien from WHO said a year ago, I never seen anything going smooth in vaccine development. And we had the first vaccines in December last year. Therefore, we have seen an amazing achievement of science and engineers, development and scaling up, and partnership, within COVAX and beyond. But people normally forget how challenging it was. If you think about, and you don't hear much about it because companies are not that good in bringing up their failures to the investor relations meeting. 3 of the 4 biggest vaccine manufacturers pre-COVID don't have a vaccine. And we still have actually trebled the global vaccine manufacturing, thanks to a German biotech company doing, collaboration with a big American company, thanks to a startup company like Moderna, thanks to actually unprecedented collaboration with the developing country vaccine manufacturer network, volunteer licensing, tech transfer. When I look at COVAX, and Seth Barkley actually indicated some of the challenges, COVAX for me is really a unique partnership and on the road to fulfilling what it set out to do, despite the challenges it faced, because Seth indicated exceeding 400 million dose delivery now. More than 80% of supplies to low-income countries came from COVAX, not from bilateral. 30% of low and middle-income countries came from COVAX. And over the next 6 months, you can expect every month as many vaccines rolled out as were over the last 10 months. And I also heard from Jens Spahn last night that Germany in the donation program is increasingly getting pushback from countries who say, we are not ready. We don't have the absorption capacity. Therefore, when you look at that, nothing coming out of India, to the best of my knowledge, no COVAX vaccines from China yet. Big manufacturing scale-up problems with the big innovative vaccine manufacturer. And 4th, no vaccines yet from a 4th biotech vaccine manufacturer because they're seriously delayed in their regulatory approval system in getting the dossier. It is amazing that we will exceed 9.3 billion doses manufactured end of October, more than 12 billion end of the year, and probably 24 billion next year, which means we are really moving big way from the big shortage problem, which was about raw materials, the trade barriers, the export bans, whether it was from the US, from India, to having sufficient supplies and really challenged on distribution. We from the industry, we called out in May for a 5-step program, because we said industrialized countries, they moved from hedging the risks because you didn't know which vaccine would work, and some did fail, to hoarding, to having, even if you take into account booster shots, about 1.2 billion excess doses by the end of this year. And we now need to make sure that these doses get to the people. We need to continue optimizing production. We can't afford to have trade barriers, by the way, including of syringes, specialized ones, which you need for the Pfizer-BioNTech vaccine. We need to make sure that the countries are ready, and there we need to work on transparency in terms of delivery schedules, where manufacturers already also are tasked to come forward with information. And we need to continue innovation because we don't know yet where the new variants will come up. All the vaccines are highly effective, for most of them against the Delta variant, but we may see other variants, and then we better are prepared for that. Therefore, I think we have a huge program. We are in this together, and we need to do this in partnership.
Indeed, partnership is very important, and we can agree with all of that, Thomas, but fact of the matter is that some countries have enough doses to vaccinate 150% of their populations. When we talk about all the other bottlenecks that are real, fact of the matter is we all say none of us is safe until we all are safe. well, how does it translate really in concrete terms in policies and programs? I think this is a challenge that we are facing, and each partner will have a role to play here. Can you tell us just what would be the one important role, that the manufacturers will play in that, to move from the rhetoric, to the practice?
I think actually manufacturers to a large extent are already walking the talk. When you look at, for example, the scaling up would not have been possible without the 300 plus collaborations partnership. I've seen big vaccine manufacturers and big pharma companies whose projects failed, who had quit vaccinations like Sanofi, like Bayer, like Novartis, offering their capacity to make sure that scale up happens. We have seen more than 200 volunteer tech transfer between developed and developing country vaccine manufacturer. Serum Institute has been mentioned. Biological E in India is really a big one. Aspen in South Africa, most recently the collaboration with BioVac in South Africa, Eurofarm in Brazil. Therefore, this is happening, but it's not, and therefore we need to continue to do that. And one element which can't be happening short term, we need to look at Africa and Latin America, the two continents which honestly were left behind because they had no vaccine manufacturing capacity. And there I do applaud the German government's, for example, roundtable on vaccine manufacturing in Africa. I'm lucky to be invited to be part there. We do, but this will be relevant in 5 to 10 years and not in 6 to 12 months. This will take time. We also need the time to make sure that we do not invest in plants and capacities which in 5, 10 years will be idle, truly cold. Therefore, you can invest a lot of money if you're not well prepared. And the most important short term, and Seth Barkley did call out to us manufacturers, we really need to find ways and means to improve the transparency, the predictability on the deliveries, be it from COVAX contracts or be it actually sitting down with countries willing to share doses to address all the complexities, be them logistically or be them legal, to make sure that these doses can be shipped before the shelf life expires.
Thank you. We are saying that there are many dimensions, popping up here. We have the science, we have the manufacturing side, we have the logistics, but also we have the political dimension, of that. And when we talk politics, we talk also leadership. I cannot resist before giving you the word, and Henrik Roller, to salute the leadership of Chancellor Merkel and the leadership of Germany. I think the world will miss her, very much. So my question to you would be, what can G20 do and how will Germany make sure to use its G7 presidency to ensure equitable access to vaccines in the very near future?
Yeah, thanks very much. And great to also see colleagues on the screen. I'd like to make 3 comments. I think the first one is a more general one, alluding to also Chancellor Merkel, that actually Germany in its presidency at the G7 in 15 and in 17, we always put health at the center of the discussion. And at that time, some of you remember that most leaders didn't think health was an issue, in particular for the G20, because that was supposed to be about economics. But we pushed it very hard. And actually, I think it has sort of paid off to some extent. Now, if you look this year, that's my second comment. If you look at the G7, I think we made a number of promises there. And I think it's very important that the G7 delivers on that. This in particular on dose sharing. And I think Germany, I don't have the numbers right now, I think is doing pretty well. I think Minister Spahn also announced that we would do more, but also the financial compensation to ACTA A and COVAX. The money not only has to be pledged, but it actually has to also arrive there. And with CES, I discussed it many times that is there. So I think following through on the commitments which leaders have made is very important. Then we have a G20 summit this week. And I'm, quite concerned about the G20 because we really have 2 issues where, there are challenges, and it's not only One of them is climate, in particular climate financing, which is also related to health, by the way. And the other one is the health issue. And I think on both of them, the world will be looking towards Rome and will think about how we can sort of bridge the gap, and equity and localized production, all the things we've been discussing, following through on commitments are going to be smack in the middle of the G20 discussion. And in fact, I'm going to Rome tomorrow to start the negotiations at the Sherpa level, and I hope that we will get further. One thing which we also do in the G20 and is that we have prepared a report, a political report by the Vaccine Manufacturing Working Group, which is going to be published this week. These are about 8 or 9 countries, together with a task force involving Gavi, CEPI, and the WHO. It's commissioned by the Facilitation Council of ACTA-A, where many of these recommendations, which you're asking for, very precise, are made. We'll be presenting that to the G20, and it'd be very interesting to watch what the outcome of the G20 is with that regard. But it's a big, challenging issue for that one. Final remark, next year, Germany has the G7. Again, the agenda for next year is something which the next German government is going to have to decide on. So I'm not in a position to give you what the agenda would be next year, but I think some of these issues will obviously propagate into next year. I think one issue is, again, this equity issue. I think that is going to be smack in the middle, if I may say so, also of the German presidency. The other one is the global architecture. I think there are some issues which we'll be discussing also in the G20. There's some proposals on the table, you know, a global health board, like the FSB, which we had in the financial crisis. And there are other issues which involve other international financial institutions from some countries, which we'll have to deal with. And I think this architecture and how we manage it as we go forward is going to be a big issue also next year, I think, for the German presidency. The German position is very much one of strengthening WHO. I think this is our view, and the Chancellor has been making that very clear many times over. And the final issue, which I think next year, you mentioned the 70% goal, if that's in the middle of 2022, you know, it's, I don't think it has been decided yet, but it's likely to be a round of the G7 summit. It's usually G7 is in the middle of the year and G20 is a little bit later. So that would be also something which the German presidency will have to deal with, that we achieve that global goal by the time we get to the German presidency.
Thank you. We know that those of you who know you and have been part of this response have seen your role as the co-chair of the COVAX Vaccine Manufacturing Working Group, where many of these issues are being discussed and addressed. But can you give us a sense of what you would recommend to G20 country leaders, you know, based on all that experience and analysis made so far?
Yeah, this is commissioned by the G20 leaders itself, and we'll be presenting the report this week. We already sent it out to participants, I think on Monday. It involves Brazil, China, India, Indonesia, Korea, Norway, Rwanda, South Africa, and the United States. Those are the countries involved. And the idea was to have a political positioning to the task force which has been created earlier by ACTA-A Facilitation Council, which involves, as I said, Gavi, CEPI, and WHO. We're now presented, after having worked pretty intensely for the last 4 or 5 months in this group, our recommendations to the G20. Again, you know, these have not been published yet, but we'll be calling for, there are 3 work streams, a short run, a medium run, and a long run working streams. But we are calling for a marketplace which has been already initiated by the task force of input supplies. So we're asking for more participation by the manufacturers. We also met with the manufacturers. I think you were also there several times. So I think getting the input supply market going. We'd like to promote what Tess was saying, early delivery, including swaps and more transparency in the contracts, which is also a topic you've been confronted with. And we are asking WTO and WCO for more efficiency and less restrictive measures in the area of trade and customs. I think the customs part is also a big issue. So that's area one. Area two will be looking at things of boosters, and we'll make a pretty, which we discussed for a long time in the working group, a pretty sensible suggestion that should be based on clinical evidence. The booster, we're calling for less stockpiling, and we're also talking about this issue, which is a big issue, going from from multiple vials to single dose vials, that should only be done after an equitable access is achieved. So those are some concrete proposals to the G20. And the final one is the long run, which is the localized production. There's several models you can think about localizing production. And in particular, we have an mRNA hub or a hub in South Africa, which is like a first one. There'll be others to follow. And here again, you can think about fill and finish. You can think about more localized production. There's some German companies also involved in that, in particular in Africa, German government also in Senegal and Ghana is something where we put some money, some government money into that. So you can have localized productions. And the final step is, of course, something which some of these countries are calling for, which is equity. So that actually the ownership of these localized production is not foreign, let's say, but also localized through joint ventures and these kinds of things. So we're pushing for that, and we have some concrete proposals.
Thank you so very much for sharing with us in advance some of those very concrete and pertinent recommendations, I would say. Let me now turn to you, Jane, Jane Holton. CEPI, I think we can say, has been mindful of equity right from the beginning. And that is the reason why I think you made some very crucial investment, early on. What, in your opinion, could have been set up differently that could have avoided such an unequal access to vaccines, which is really the contrary of what you would have wished for, based on the engagement and the investment that CEPI has made? Over to you, Jane.
Thank you. And like Seth, I apologise that I'm not there in person, hopefully next year. This is the most vexed of questions, something which troubles us deeply. The inequity in the distribution of vaccines is antithetical to what CEPI stands for. CEPI has had at its absolute heart doing research, creating the potential to provide protection for people, in this instance against COVID-19, but of course our mission is broader than that in respect of other priority pathogens. But actually enabling us to not only develop these vaccines, but then to ensure that they are distributed equitably. You're right, that has been at the core of what we've done. And if I look around the world and I look at the situation in Sudan, in Papua New Guinea, in a whole series of countries in Africa more broadly, but also in other countries, some of the European countries, Ukraine, for example, we have not seen our mission delivered on, and that is really troubling. So there's two things I'd like to point to. The first of which is we have gone to the world and said, help us invest in the development of vaccines. We are stronger together even in the research work that we do. And we were very fortunate to receive significant investment from countries around the world, including, can I underscore, from low and middle income countries. And I acknowledge the Ethiopian minister because Ethiopia was the first low income country that invested in CEPI, and we were delighted with that investment. But what we haven't been able to do is we haven't been able to secure the purchase of those vaccines in an equitable way to ensure equitable delivery. So where we have been the large majority funder of a candidate vaccine, and in fact in every case where we've been an investor, we have struck agreements with the developers to ensure that we get access to those vaccines. Now, of course, where we are an early investor, where we are a large investor, we have actually been able to get more access to those vaccines. And of course, some of the vaccines that we've talked about, so AstraZeneca was an early investment, I think everyone knows Novavax, and we've got another very promising vaccine coming forward in Clover. But if we are not the only investor, our rights to actually access those vaccines, maybe we have to share that distribution, that manufacturing capacity. But most importantly, we also have to have the funds to purchase those vaccines. And Seth can tell you, Thomas can tell you, there are a number of people who sat feeling, I think, quite perplexed, disappointed, in some cases really aggrieved, watching the contracts that were struck early last year, and you've talked about this yourself, looking at those contracts and knowing that we were not in a position to strike similar contracts in the same time frame. And so the challenge we have is to be a big investor in research and development, but to be able to translate through the leverage we get with those investments into the rights to purchase, and then to look to see that manufacturing is also distributed equitably. You've talked, and a number of your speakers have already talked about this importance. And this is something that I think we need to remind ourselves of, that the capacity for a number of countries to be able to actually manufacture is, I think, fundamental to also ensuring that we can deliver equitably. So certainly from a CEPI perspective, and we have been a core partner, a firm partner in the development and the rollout, including of the COVAX mechanism. I am the co-chair of the COVAX coordination mechanism. And we have not just limited ourselves to the scientific bench and to the work that is done in organising trials of candidate vaccines. We have been actively engaged, and you're right, we did make some investments that were perhaps a little bit unusual for our organisation to actually try and guarantee issues around supply. So we see our role as being not just the innovator and the body that can, if you like, encourage and facilitate the development of candidate vaccines, not just in a pandemic context, but we also see ourselves as fundamental to the delivery of these things, these vaccines equitably around the world. And it pains me that when I think of the work that was done after the Ebola outbreak, where we all sat round and we said, this cannot be allowed to happen again. And we might remind ourselves that we couldn't deliver a potential vaccine in that context. So we said, well, we need to be able to actually produce these products, these vaccines. But what we haven't done yet is solve the other parts of this problem. We need to solve not just for how we identify the pathogen, how we get that detail to the research scientists and the people who can develop these vaccines. But we have to do what is necessary for the entire supply chain so that we have the firm financing in place. So as we actually get success or even potential of success on these vaccines, we too can take our place in the line equitably, so that we can then ensure that the work that is done to actually produce successful vaccines, and we should remind ourselves how lucky we are to have actually done successful work in this context. But that is not enough. And can I also, as it's a little bit beyond the role of CEPI, but I just also want to make an observation, and it is the point that you yourself have made about last mile. I mean, one of the things I do in my region is also work on other issues to do with delivery. And I think we cannot rest and say we've done our job if all we do is have a large aircraft fly in with a delivery, or if we have something delivered onto a wharf. That is not the delivery of vaccines. It is not the equitable delivery of vaccines. A vaccine is delivered equitably if we have the same rate of vaccination in all of these countries. And sadly, today, and it pains me to say it, when I look at the map of the world, that is not what I see. Now, Seth has talked about the hope that we see, particularly with the additional manufacturing and with the commitment of doses towards the end of this year. So I live in hope that we will see those doses not only produced, then shipped, but then they will be delivered to the men, the women, and increasingly to the younger people around the world who need them. And I would say this, that I would encourage all countries to think about whether they really need all of those booster doses until such time as we actually have the whole world properly vaccinated. There are some people who might need them, the immune compromised, people who are occupationally exposed, and probably the elderly. But let's think about where the evidence takes us, and it is about delivering vaccine equitably right around the world. Thanks, As.
Thank you. Thank you very much, Jane. When hearing you, while we celebrate progress, while we celebrate all the efforts that have been made, and applaud the leadership of many from different sectors, using your own words, it pains. It pains really to see the situations in which we are. After Ebola outbreak, we warned against, cycle of panic and neglect, that we are panicking when we get to something, and we decide we neglect again until we face, the other shock and then hazard. We are seeing also the irrational behaviors, that are happening right now with boosters and holding on vaccines, what we call nationalism. Well, that is a nice word, to put on those kind of behaviors, which is quite, irrational in many ways. But what we have not said, and I think we have to be mindful of, is the fact that this is providing a fertile ground to all the naysayers, to all the anti-vax campaigners who are using these dysfunctionalities in a vicious way that is impacting negatively on behaviors and attitudes of people, one of which is vaccine hesitancy that we are seeing happening also across the world. So thank you very much for this first tour and for your insight. And I'm going back to Carolina, that may have also some questions as well as comments from the audience and virtually through the iPad.
Absolutely, thank you, As. I think we have actually a couple of questions from the audience, the virtual audience, that are very fitting to the last comments that were made by Jane and other panelists. So we have members of the audience asking specifically what is being done to address the difference of vaccination, not only between richer and poorer countries, but between urban areas and rural areas. As you said, once the delivery is actually at the airport, at the wharf, what is being done to improve the differences? The members of the audience are saying, living in a rural area, and there's a huge division in this case in Kenya between what is being delivered to the big cities versus the rural areas. And in addition, also what is being done to ensure that refugees who live in refugee camps and often have poorer access to any healthcare facility, that they have access and can get the vaccinations they need for COVID. Minister Tadessa, I was curious if you could maybe share some impressions in terms of the urban-rural divide and also the nature of refugee camps and the lack of infrastructure there. How is Ethiopia approaching it? What are some of the observations and impressions you have on how to do it well?
Thank you very much. Yes, well, initially when rolling out the vaccines, of course, we try to prioritize based on vulnerability of the disease and the risk of morbidity and mortality. So those frontline workers across the nation were given priority, like health workers and then other frontline essential workers. So to achieve, and also next to that was also, of course, with older age. And to achieve that, the rollout was done throughout the country, both urban and rural. Of course, the preparation needed time and resources, like trainings at all levels needed to be cascaded and get our systems ready. And then, of course, as I said earlier, the supply chain and distribution was a key issue which we were able to manage. But also going forward after that, the initial phase, the other, of course, priority was to address other at-risk population progressively, like IDPs and refugees included and other who are in congregate settings. And but while we do this, one of the key challenges, as I mentioned earlier, is when we get doses, it's always difficult to distribute all the doses we have to all the rural communities because the number of doses are not enough. And of course, we also have to look at the burden of the diseases. For example, in Ethiopia, Addis is the epicenter for COVID, although we have, of course, COVID across the nation, and the cities are having more burden of the disease. So while we address the priority population and then progressively as we roll out, we also try to look at where is the more risk population, because we don't have enough doses. We have so far inoculated around 4.2 million doses. We have 110 million people. So you can imagine how difficult that is. So there will still be some gaps between this urban rural for some time, but it's not only because it's rural, but we also have to look at the prevalence and the burden of the pandemic as well, and trying to, when we address the cities who have high burden, we're also limiting the transmission to the rural areas with the commute that is happening between rural and urban. But that doesn't mean that we don't need to focus. We have to continuously look at addressing the priority population in all of the urban and rural areas. But the challenge is with the health system, but we also need to balance the burden of the disease and the morbidities and mortality we are seeing in our different cities. Thank you.
Thank you very much. Seth, I was wondering if you could maybe contribute a perspective there as well. After all, Gavi has quite a bit of experience in delivering vaccines in all kinds of settings, even if, of course, the current COVID-19 vaccine situation is a little different. What do you think needs to happen that rural and particularly also refugee settings can be better served more broadly?
So first of all, I want to compliment Minister Tedesse because, she said exactly the answer you would want a Minister of Health to say in every aspect of that. Now, why do I say that? The original plan for COVAX was to try to get coverage of high-risk groups across the world. The idea was 20%. It wasn't that was the ceiling, that was the base. And the reason was, as she described, if each country could cover all of their health workers, about 3%, and then cover their elderly, which in lower income countries is a smaller percentage of the population, and those with comorbidities, you would get at least initially some protection as you were moving towards broader coverage. So that critical issue of trying to prioritize those at risk, which we can't control. We certainly ask countries to do that. That's what the WHO recommendations are when they apply, but that prioritization is critical. Second prioritization is to look at the epidemiology of the country. And if you have an urban setting, then obviously it makes sense to initially focus in the area where more transmission is going to occur to both protect people there, but protect the rural areas. So I think what she's saying is exactly right. The third issue is we, of course, want everybody vaccinated. That includes refugees, it includes IDPs. The challenge is we ask that they get included in the country's plans for vaccination, which is what Dr. Tedesse has said. There is also a humanitarian buffer that was put together, and that takes about 5% of the doses that COVAX has. We've had now 2 applications approved. There's a number of other applications that have been put forward, and those are for populations that don't sit within a place that can be included in the national plan, for stateless people, for conflict settings, and particularly for places where you need humanitarian agencies to be able to go in and provide the services. And that has been a little challenging to get started because one of the critical things for vaccination has been indemnification and liability. And the no-fault compensation scheme we put together to help industry with that. For refugee camps and for humanitarian agencies, of course, they can't guarantee those issues. And so what we've had to do is ask them if they would be willing to waive indemnification and liability. And now a few companies have done that, but not all companies. And that's something that we're asking going forward so that we can get to universal coverage. Last point I'd make is not all vaccines are equal in terms of their ease of use. We have very effective vaccines like the BioNTech Pfizer vaccine, but requires ultra cold chain and is therefore, a little bit more difficult to use, specific size syringes. You have other vaccines like the Johnson & Johnson, which is a single dose. You have other vaccines that are 2 to 8 degree with, easier to store capacity. And so what we'd like to do ultimately is make sure countries have a mixture of the vaccines that are appropriate for their setting so that they can help work through the different parts of their system with the most appropriate vaccine, making it as easy as possible. And for that, we are providing financing along with our other partners. Back to you, Caroline.
Thank you, Seth. I think it's really important to be reminded, again, as we talk about these 40% and 70% goals, as you said, Seth, is to keep in mind that countries are obviously very different in terms of their epidemiological structure, in terms of the age stratification, and thereby also in various ways of the risk stratification. So hopefully, if and when we had a wish, the German G7 next year will potentially pick up these targets. One could hope that these differences and also the need for the need for data to be able to actually say who's been vaccinated in which group, whether it's by gender, whether it's by age group, whether it's by socioeconomic background, that kind of data is often not available in many countries. And that's what someone in the audience is also pointing to, that that much better understanding for that is needed. I'd like to share one more question from the audience with Thomas Cooney. It was just mentioned by Jane that there were very different contracts and type of conditions that were possible to be struck in these deals early in the day between individual countries and certain manufacturers compared to the conditions that now COVAX has been able to negotiate. Could you comment on that? Is there an easy understood reason for that? Is that something that you think will be changing?
I think there are multiple reasons for different contracts, technology platforms, the way the manufacturers operated. We have had manufacturers supported by CEPI, for example, or supported by BARDA. We have had one major manufacturer who upfront said, we do not want to get money from the government for the risk sharing. We invested risk. Those are different. And when you look at, it's also a question of company history. Now, some of these issues are extremely complex, and to be honest, it is something where industry collectively cannot negotiate. Our general counsel would, see me handcuffed going to jail if I would try to negotiate either an overall industry approach to being contracts or prices, because they are antitrust and compliance rules. I think a major achievement for COVAX has been to get this framework indemnification liability, no fault compensation. I think a second major one, and I hope Jane and Seth won't mind me saying, COVAX gets best price guarantees. And they should, but it would be much more challenges for them if they would start publishing their prices. And I think one of the elements where the industry has really done, if you would have asked me 18 months ago, will the industry do this in a way which society would hope for, which means affordability, an element in the pricing. I think every single company has committed to tiered pricing. Some companies have committed, we will do it not for profit during the pandemic, and they stated this publicly. Others committed, and by and large committed to for cost for COVAX. When you look at actually the most successful one in scaling up, 99.8%, output delivery when you look at the manufacturing, that's amazing. That's the one German with an American partner. They basically say, and the rich countries pay the price of a meal. Now, my reaction to the CEO of it, you couldn't get far for a meal with the price of your jab in Geneva, about $25. As it is, I'm getting my seasonal flu shot this Friday, and I hope that actually many people will not forget that seasonal flu is still upon us, and we are probably less protected than in normal seasons because we were wearing masks, not shaking hands, not kissing, whatever. For my seasonal flu shot, I pay about 40 Swiss francs, which is significantly more than for this COVID jab, which for God's sake doesn't have a 30 to 50% efficacy, but a 95% efficacy. Therefore, I think the industry in terms of doing that, the one element, and I want to add this, is where we really, all of us need to think, how can we do what Seth and Jane said? The original allocation plan was 1% frontline healthcare workers. I'm not quite sure that all the countries have done that. The 20% vulnerable, which means the elderly, which in Japan is clearly more than 20%, in many African countries, it's less than 20%, sort of forgotten. What can we do in a future pandemic to really commit to something on equitable, accessible, and since Ars is the chairman of the Kofi Annan Foundation, I'm of a certain age, so that I still recall the Accelerating Access Joint Statement of Intent, which Kofi Annan signed with Gro Brundtland for WHO, with industry CEOs, which was about, we need to do better on HIV/AIDS. It only worked, and I think that will be the same for the future, once you had the Global Fund providing significant funds for global rollout of that. And that's something which needs to happen, and Professor Rolle mentioned it. If we want to do better, there needs to be fund available for the AMC countries who need to be funded.
Thank you. I have one more question. It's actually not from the audience, but it's gathered from a group that is the next generation leaders in global health, which was instituted at the World Health Summit a few years ago. And I think it's a question potentially for you, Professor Rolle. It's a bit of the economist side of things. The question is, we're approaching this pandemic, we are now approaching how we look at the pandemic, and particularly vaccines, in a way that they should be global public goods. It's a sort of risk pooling phenomenon when you look at a pandemic, but really the logic doesn't work. It seems like individual actors, countries are not acting according to a global public goods logic. Since you're negotiating also on climate, where that is kind of the predominant logic behind how countries should work together, do you think thinking about it as a global public good approach to achieve equity makes sense? Is that what the actors behind closed doors really embrace? Or is it something that we should hold as an ideal, but be more realistic about?
Yeah, I think it's still the right approach, just like in climate. But I think we need to be able to deal with it, as was just being discussed, in a way so that not everybody does what they want to do. This issue about nationalism, and we faced it very much in the group about production. I think we're moving from a phase where we had not enough to something where we will have abundance of production. I think the factory in Marburg, BioNTech, I think has a capacity of 1 billion. If I'm not mistaken, and I think they're getting close to that. That's a lot, and I think Germany is also right now in the process of issuing these pandemic preparedness contracts. And I think this is public. So some of your companies are participating in that. So it's like an insurance mechanism where you put some contract where companies would be willing to produce within a certain amount of time a certain amount of doses. So you're not buying doses like in these APAs, but you're buying an insurance mechanism. And I think this is happening in many other countries where production capacity is being incentivized with taxpayers' money, let's say. And I think that's good, if it then also helps solving the global public good problem. And of course, that's where the problem has been, that because of trade restriction and other kinds of restrictions, export controls or semi-export controls, it hasn't been sent to where it is mostly needed. And of course, if you go to a world where it's abundant, it may not be the case anymore, because the incentives for politicians to restrict exports isn't there if it's abundant. I'm not sure the developing world buys that argument. And this is why we started to talk about localized production. And now if you add a lot of capacity in the developing world, I think this is a point you made earlier, for example, through hubs, which is good and which I think we support, both our companies to a certain extent and certainly also the German government, and our recommendation will be there in that direction to the G20 leaders. You got to look at, where are we going with all this capacity? And I wonder whether you're moving from a global good problem also in an industrial policy issue, that you actually like to have a comparative advantage in this markets, which is a legitimate goal for most countries to have, like in many other fields, but it's not really the public good aspect. So I'm a little bit worried about needing to coordinate all these activities. And this is in a way what ACTA-A and COVAX was. It was the answer of the G20 to a multilateral answer to the predominant issue of the last 2 years. And I think we need to do much more coordination, also on the financing, as you say, in terms of moving in that direction. So I think the word global public good is fine, but I think that you need to have the actions, which actually, as you have asked and you've been addressing, to make this truly a global public good and not a local public good. Which I think is a challenge for the multilateral approach to the health crisis.
Thank you. Thank you.
And one other point, if I may say, I think on the antitrust issue, I've been in antitrust for most of my life. I think there are rules to that, but I think antitrust is also, if sort of the benefits from cooperation, Article 102 in Europe, if the benefits of cooperation is stronger than the possible restriction you get on competition by cooperating, then antitrust rules in Europe allow you to do that. So you just need to apply for it and discuss with the antitrust lawyers. Now, if it's on price coordination, that's a per se no, but it's on coordinating on production schedules and swaps and having more transparency on some of these contracts. I wouldn't give up on that angle. I think the benefits are bigger than the costs, and I think antitrust accommodates that.
It's an important reminder. Thank you. Before we go to our very last sort of very short fire round of questions, I would love to turn over to you, as you also have a very important perspective by having served in civil society for many, many years. And obviously you're also currently based in Dakar and see what is the situation on the ground. What are your impressions having followed this conversation? Do you feel that the perspective of civil society, of sort of, those that aren't currently in most rooms where negotiations are being made about how this pandemic is being solved, is adequately reflected?
First of all, we often complain about lack of data to really understand the situation out there in communities, and in countries and most remote areas. But there are some data that is available, and I think that is we cannot dispute. And some of those data suggest that 90% of doses, are going to 10% of countries, roughly. It says something, and this is not, something that is rhetoric. It can be, proven when we look at the data and then we find it. So it says then indirectly that the place you live, becomes, the most determinant of your health status, and also determines, your access to commodities, and mostly determine, will you survive it, or not, when that is fact of the matter. And if it has to be a true national response and a true global response, it has to be an inclusive response. And I think that is the perspective that civil society organizations are asking for. Not only now, but always. But now what civil society organizations are feeling is that they're being betrayed in many ways, because so many promises have been made and so many promises have been broken without any consequences. Leaders can meet in General Assembly, special sessions, and make commitments. Very few delivered, and then so what? the consequence of that is, trust is being eroded, and there will be, no inclusion, no real partnership without the trust, that can be built between leaders and citizens. And that's the reason why, again, we need strong leadership at all levels. And the world is crying for that leadership, honestly. Well, again, we salute it, and I cannot repeat again how much the leadership of Chancellor Merkel was appreciated, the leadership of Germany was appreciated. We would wish, that that is not examples that we can only count with the fingers of two hands, but a critical mass, but we are not there. But it is not only leadership alone, it's going to be active citizenship that also will be required. Citizens will continue to challenge, and they're becoming impatient, rightly so, at times angry, rightly so. And I think if we would like to see the type of social cohesion that we would like to hope for stability, for a culture of peace, for a culture of nonviolence, for a cohesive societies, it is in our common interest of all of us to invest also in better health, for all. And that is, again, showing the multiple dimensions that we are seeing. Well, the situation is also a test for preparedness. And I don't think we passed that test. In the GPMB, we produced a report 2 years ago. We called the world at risk. The world was not listening. 6 months later, we had COVID. A year later, we produced another report we called The World in Disorder, that we need to get our act together and then respond effectively in a cohesive manner, in an inclusive manner that will, again, include civil society, private sector, countries, and the like. Well, we are not there yet. Tomorrow we'll launch another report. I'll invite you tomorrow that we will not whine on that is not working, and hopefully get to some recommendations that will drive us all in a path where we can do things better. So more tomorrow on that.
Great. Thank you very much. As with that, I think we will turn to our very last round of questions. It's a rapid fire question round, which means each panelist has 1 minute to answer. Please do name the one thing you will do next to advance vaccine equity. And I will start with you, Professor Rella, since I think you're getting on a plane tomorrow. That probably will be part of that answer.
Yeah, I will. It's obvious because my time is also limited. I'll go there tomorrow and I'll negotiate for the G20 to get that leadership and keeping of commitments which we've made in the past, including launching our report, which I think is a multilateral approach from many of these countries which are directly and indirectly affected. So making some progress in the G20 is what I do starting tomorrow.
Fantastic. Turning to our virtual panelists for a moment, Seth, what is the one thing you're doing next to advance vaccine equity?
We have signed deals for 4.5 billion doses, and I've already talked about the number of doses that are there from dose donations. We need to make sure those really are delivered in real time and push that. And of course, even though you only said one, we have to make sure that they get into arms and that countries are ready and are supported in what the infrastructure they need and the technical assistance they need to be able to inject those so we can protect the world.
Great. Thank you, Seth. Minister Tadesse, what is the one thing you're doing next to advance vaccine equity?
It should be many things, but making sure the vaccines that we are receiving are going into people's arms, as Seth said. So to really work on advocacy in that regard with the different actors, leadership, religious leaders, and many other actors to make sure that all the vaccines we are receiving are being into people's arms. So this is a big priority for me. Thank you so much.
Excellent. Jane, over to you.
Well, I'm not repeating things others have said. I'm actually going to be arguing that we never have this happen again. I'm going to be arguing that we need to invest not just in the platform for research for all the other pathogens that are out there that can cause this trouble, but that we actually ensure we have the mechanisms in place to ensure right at the get-go, when we have this kind of crisis, that the funding is available. So we can not only design, invent, and then produce these vaccines, but then we can deliver them equitably. We can do better than we are doing now, and we have to do that with the way our system works. So I'll be doing that if it's the last breath I have.
Great. And Thomas, what about you? What is the next thing you'll do to advance vaccine equity?
I first need to say a word and qualify what Us just said, because this is not quite the same as the HIV/AIDS one was, North versus South, rich versus poor. When you look at half of the vaccines administered so far have been administered in China, 2 billion, India, 1 billion, and Brazil, which is the 5th largest. None of them are really, classic rich countries. Having said that, I see a turning of the tide. And as said, we need from the manufacturers to help COVAX deliver and make sure that we can move from the 400 million so far to the 2.6 billion end of March, and basically vaccinate all those who want by the UN General Assembly next year, as President Biden announced in his summit. And the manufacturers need to play their part.
Okay, so manufacturers playing their part in ensuring by next year's United Nations General Assembly, everyone who needs access to vaccines.
Who wants
access to
because
vaccines.
you will have some people who don't want to be vaccinated.
Absolutely.
And I'm a little bit cautious about vaccine mandate.
Fantastic. As may I turn to you for the last word as we wrap up?
Well, first of all, to thank all the panelists for their very, very, very pertinent analysis, and beyond the analysis, the very concrete, recommendations they made, to take us forward. Again, to remind ourselves that shocks and hazards and pandemics, they reveal many things. They reveal most of the time what we can call or qualify as the worst in us. And that is the exclusion, the nationalism, if we wish, what I call egoism, frankly. They also reveal, I think, the inequalities that we've been discussing all morning. But on the other end, they reveal also the best in us. The best, in terms of partnership, in terms of sharing of knowledge, sharing of resources, sharing of information, sharing even of power in a certain instance, so that we all can come together around the same table and discuss issues. So our wish is that the best in us, prevail, over the worst that we have seen. And then the key word there would be partnership. Partnership between rich and poor, partnership between the North and the South, partnership between the rural and the urban areas, and partnership maybe between this generation and the next one, so that we do the right thing, to have the future we want, tomorrow for the next generation. And a partnership finally for us, for better preparedness, and then to build trust moving forward. Because the most difficult thing is to build trust in the middle of a crisis, to build trust in the middle of a pandemic. Well, let's work together, to bring it to an end, and then be prepared for the next one. And thanks again.
Thank you very much. And big thanks to everyone on the panel for your time, and for the audience for being interactive and such a great audience to contribute to. Thank you very much.
Thank you.
Thank you.
Thank you.